So we will go ahead and get started with our seminar speaker for the month of March. We're very lucky to have one of our colleagues from up the road at KU Med joining us today. Dr. Tanisha Schuerman is a trained counseling psychologist and associate professor in population health. And she earned her PhD in counseling psychology from the University of Akron and did a postdoctoral fellowship at the Center for Health Equity at the University of Minnesota. Her research emphasizes health disparities, including racial and ethnic and socioeconomic disparities related to tobacco use and associated health outcomes. And she's focused on several populations. Today, we're going to hear about her work with pregnant women, but we talked about other populations that she was focusing on in our conversations this morning. She's been funded by a NIDA K01 Mentored Research Scientist Development Award. And she's also pursuing a research program focusing on implementation of evidence-based smoking cessation interventions. She'll be presenting her research and findings from a longitudinal pilot study on feasibility of a mobile health smoking cessation intervention for pregnant and postpartum women. We're especially excited to have Tanisha here today because she's right up the road, and she and I had conversations this morning about projects that they're launching at KU Med. And I think it's a great opportunity for us as an addiction center here in Lawrence to partner, to build more partnerships, more than we already have. I mean, we obviously partner with Laura quite a bit, but more of those partnerships, especially on the smoking cessation side. So Tanisha, we're very excited to have you here today. And we look forward to hearing what you have to say.
So I'm excited to be here and to talk about the series of studies, and we have a small group here, so feel free to interject with questions, and I will leave time at the end also for questions, so either way, it's fine. I just wanted to acknowledge my mentors and collaborators on this project, including several folks in my department, but also Catherine Pollock at Duke, and I will talk about some of her work as well. And Elena Shardina is a PhD student in biostatistics, and so she's been wading through all of our data, which I'll be describing. So, as Michael said, this is funded by a K award, and we also had support from a P30 for our analyses. So the biostats effort was supported by that. So I'm interested in smoking during pregnancy. We have, smoking rates have been declining overall in general, and smoking rates during pregnancy have been declining. In Kansas, there's some counties though that have disproportionately high smoking rates during pregnancy, ranging upwards of 20%. So although there's this overall trend in declining smoking, it's not equal across groups, and it's certainly not equal for lower income women. We're seeing higher rates of smoking, especially for women enrolled in WIC and women with less education. And we also see higher smoking rates among women 20 to 24 years old. Now, what's interesting is that for many women, about 50% of them quit smoking as soon as they find out they're pregnant, often before their first prenatal appointment. So isn't that our interventions are effective? It's that people understand that smoking is not healthy for the baby and they quit. And a friend of mine gave me sort of the perfect analogy. She said when she got pregnant, she quit drinking coffee. And she had a baby and she resumed drinking coffee. And so even though we wish women would quit permanently, many of them, as much as, honestly, as much as 90%, return to smoking by the time their baby is 1 year old. So one of the reasons for this study or this focus is also the fact that it is sort of this unparalleled opportunity. We've got relatively healthy people. We've got healthy people, in their 20s, 30s, with significant contact with the healthcare system. So there's several reasons to focus on smoking during pregnancy and postpartum. One is that smoking impacts pregnancy and maternal health outcomes. Women are already making changes, so they're used to the message of you're doing this, to improve the health of your baby, for your own health, and there's this significant contact that could be utilized. So I'm not really going to talk a lot about this qualitative research that I did, but prior to starting the cohort study and the pilot trial that I'll talk about today, we did some interviews with providers. And so we asked them about what were their smoking cessation practices, how do they encourage people to quit smoking? And so routinely people are assessing tobacco use. It's usually part of their intake materials. But what is happening less often are those conversations around smoking. And also, if there is that conversation, often there isn't that follow-up. And providers reported that there are very few options for providing ongoing follow-up. And with all of the things that they have to discuss in prenatal care, smoking isn't going to come up all the time. So we conducted a cohort study that would include intensive data collection during pregnancy and postpartum to understand patterns of smoking and abstinence, to describe tobacco treatment quality across healthcare visits, and to determine what factors were associated with quitting and smoking. So there have been previous cohort studies with much larger samples than what we used. But what we did, we were actually assessing smoking every week via text messaging. And so we wanted to see if we could get a more nuanced approach to understand what are the predictors, because often it was we would find like large studies that had retrospective data analysis. So you report on were you smoking before you were pregnant, and everything would be retrospective reports. And so we could do this prospectively over time. So we plan to recruit a cohort of 60 pregnant women, and we focused on recruiting from obstetrics clinics and health departments. We sent weekly text messages, as I described, and we did online surveys. So we emailed women their surveys, and we followed up by phone if there's no response. We also followed up by mail if we couldn't get by phone. And the eligibility was pretty open. So we wanted women who were pregnant. So initially we were recruiting first to second trimester women, but then this is a difficult recruitment. And so then we expanded to the third trimester. And the real eligibility was that they smoked in the 6 months before becoming pregnant. So it doesn't matter what their smoking status was at the time that they enrolled. We just wanted people who were at risk for smoking. And then a few other criteria included, did they have a mobile phone, and did they have email? We enrolled one person without email, and we had to call her for each of her surveys. Okay, so this diagram just outlines what we were doing. So the green box represents our weekly text messages. So we were asking that from the time women enrolled to 1 year postpartum. We had 5 surveys, so we had baseline that they completed at enrollment. So in order to enroll in the study, they had to complete that baseline survey. Then we had a follow-up third trimester, and only one participant missed that because we enrolled her too late to be able to complete a third trimester survey in addition to baseline. 1 month postpartum, 6 months postpartum, and 12 months postpartum. The other piece of this was we wanted to assess the tobacco treatment quality. And so our aim was to assess tobacco treatment after 2 prenatal visits, 1 postpartum visit, and 3 well baby visits. So these were our weekly text messages. So we asked about past 7-day smoking. So we asked whether they smoked, how many days they smoked, In the past 7 days, we asked how many they smoked on the day that they smoked. So they're cigarette per day, and we asked about craving. Okay, so then we asked about whether or not they had a provider visit in the past week. And we also asked if they had an upcoming provider visit. And this was so that we could administer the patient exit interview. So we actually asked if they could tell us like the date. And so we sent them the patient exit interview, which would measure tobacco treatment on the day that they had an appointment. So if they said they had one this week, we would just send them that survey immediately. And if they had one upcoming, we would schedule to send it on that day. And the idea was that we wanted to get more accurate data. So we had a time limit of within about 3 days for them to complete that survey. And so that was sent, it was an online survey, but it was sent by text message. So then they would click on the link in REDCap and complete that. And the patient exit interview essentially just assesses whether the provider asked about tobacco treatment, advised them to put assess readiness, assist them arrange follow-up. So the 5 A's. Our survey measures included demographic characteristics, pregnancy-related characteristics, socioeconomic status, and tobacco-related variables, such as their intention to quit, their history, their current use, including use of other tobacco products, other substance use, and psychological variables. And we'll talk a lot about depression, anxiety, and stress and coping. Our analyses will include descriptive statistics and longitudinal analyses. So we only had 62 participants, but we followed people for many of them, it could be over 70 weeks. And so we had thousands of data points, even within this small sample. And so what we did is what Elena did is she created linear splines that basically are a series of time points or lines within each segment. And so we use the splines to make the weekly data that we collected correspond to the 5 surveys. And so the knots between the splines were consistent with the 5 surveys. So the splines were fitted using R and the package splines, and then we use mixed effects models using SAS. So we recruited 62 pregnant women. So we met our recruitment goal, and we had really great retention. So baseline, of course, we had 100% completion rate, because if they didn't complete it, they were not included in the study. And we had 85% at 12 months postpartum. And we offered incentives for each of our survey completions. So first of all, they can complete it online. And participants received $25 and a $10 bonus if they completed it within 2 weeks of getting the email. And we did a number of things. We called people if they didn't complete the survey. And we really tried to follow up. We called them if their number was disconnected, if we can get a hold of them. We also sent mailings out. And so we really tried, we also got a secondary number. And so we really tried a number of methods to keep people engaged. For patient exit interviews, we had slightly lower completion rates, about 78% for the postpartum visit, and 75% for the 3rd well baby visit. One of the reasons I think for a lower rates of completion for the postpartum visit is that some of the women weren't going to a postpartum visit, and so we never captured that data. Yeah.
On the well baby visit, I'm trying to think back to when my wife and I went to those, like if you're with a pediatrician or a family doctor. I'm trying to remember whether the whether that provider would ask about smoking in the home. I want to say that they do often, right? They
Yeah.
ask, or either are you smoking in the home or using any substances in the home? So do you usually find that family doctors, and even though the visit is predominantly focused on the baby, will also ask the parents those types of questions?
Well, yes, but this is actually I knew that from a previous study. So in a previous study, we were able to see that most of the time they were asking about smoking in the home. But what might vary is like how much intervention actually happens within that visit. And so the average age of our participants was about 29. We recruited 5% Latina, and we had 45% Black or African American, 36% were white, and 19% reported being multiracial. 18% had less than a high school education, and the remainder had high school or greater. Like almost half had some college or higher. Approximately half were married, and then 2/3 were employed. So this graph shows the distribution of smoking status per week. I'm going to point out a few things. So what we did was we 0 becomes the delivery date, and then for a handful or a few participants where we couldn't capture the delivery date, we use the due date. And so that becomes our 0 point. And these are the weeks prior to delivery. And you notice that for like 34 weeks before delivery, we've got fewer participants. So most of our participants were enrolled by about the end of the second trimester. And then we had most of our participants completed the survey through 51 weeks, and we had a few that we didn't stop their text messages in time, so it went to 54 weeks. But the blue section, these are non-smokers or people who aren't currently smoking. And so we see this upward trend in increasing people who are quit through the third trimester, and then that line decreases and levels off during the postpartum period. So this line graph represents the percentage of those who completed the survey at each time point. So red are our cigarettes, or cigarette use, and this represents any substance use. So for the cigarettes, we see when we enrolled, I think we had about 2/3 who were smoking at the time that they enrolled in the study, and that number dropped to about a little bit less than 50% for the third trimester survey, and then went back up to probably about a little bit over 70% as a high point postpartum. So by 6 months postpartum, we're seeing the most number of people smoking. It's a very interesting curve for alcohol use. So women are not drinking during pregnancy, baby's born, there's a return to drinking. And the other tobacco, e-cigarette, marijuana use are a little bit more flat. The curves aren't as steep, but we're seeing around 10 to 20% use of these other substances. So here I just wanted to present a graphical illustration of the mental health variables that we looked at. And so we used the Edinburgh postnatal depression scale, and the score of 9 to 11 indicates possible depression. And we see that at baseline, our participants are just about a 10. And so they're quite a few people that I had to call to screen to make sure that, or to check on whether or not they were having suicidal ideation, because their scores were higher, or they did endorse that item that says, I'm thinking about harming myself. And we actually, just to give you a sense of our sample, a lot of our participants were actually in domestic violence shelter, quite a few of them. And so there were a number of people who were dealing with depression, or just had really stressful things happening. And what's interesting is that, at baseline, everybody's kind of similar. So people are current smokers or who are not currently smoking. And those lines tend to diverge a bit, especially for coping, stress, and depression over time, with current smokers reporting higher levels of stress, lower levels of coping, and slightly higher depression. Anxiety, using the JD2, so a score of 3 would indicate generalized anxiety disorder or potential generalized anxiety disorder, whereas most of our participants were hovering between 1 and 2 throughout the entire study. And so this is the results of our mixed effects model. And I'm going to go through each one. So these are univariable analysis. So at baseline, in our unadjusted model, on average, women were smoking about 20 cigarettes per week. So we don't have a predictor variable, and so that's not applicable. And then we see at prenatal follow-up, so that third trimester follow-up, a decrease of about 5 cigarettes per week. And by postpartum, we're seeing an increase relative to their baseline smoking. Okay, I'm talking about trends. These are not statistically significant. Okay, so adjusting for quit attempts. So at the average level of quit attempts, so these are all centered. So the average number of quit attempts, after adjusting for that, baseline smoking is about 26 cigarettes per week. And with each quit attempt, we have a decrease of about 6 cigarettes per week. None of these time points are statistically significant, so except for postpartum, so after adjusting for the impact of quit attempts, at 12 months postpartum, we see an overall increase of 12 cigarettes per week relative to baseline. And the other variables of note include depression. So we see with each increase in depression score, each point decrease in a depression score above the average, above the sample mean, we see an increase of like 0.67 cigarettes per week. Similarly for stress, and none of the other variables showed an association with cigarettes per week. But I just wanted to highlight that here we see that really that 12-week postpartum, there's just that really significant increase in how much women are smoking. So the prior graph that I showed you was really just whether or not they were smoking, and this is the amount that they're smoking. So in summary, quit attempts, depression, and stress emerge as important correlates of cigarettes per week. And so next I'm going to speak more about our pilot study, which followed from our cohort study. And also these findings are pretty consistent with the literature, that depression and stress tend to be related to cigarette use. So for a pilot trial, our goal was to develop and pilot test a text message program for postpartum women. So the rationale for this specific study or intervention specifically is that text message interventions have been shown to increase short-term quit rates. And so one study that I say here is Quit for Baby that tested text message intervention for pregnant women, and they showed a short-term effect. People relapse and the effect was no longer significant at 6 month follow-up. And we also noticed challenges with counseling uptake. And so when you talk to providers in Kansas, whether that's in WIC or at the state level, that's what's been promoted. You know, the Quitline has a special program for pregnant women. Okay, so we have about 35,000 live births in Kansas per year, give or take. If 7% of those smoke, we have about 25 or 2,400 people who smoke during pregnancy. Okay. Would anybody care to guess like how many women the Quitline, pregnant women, the Quitline serves each year? 50, did you say 57? Right? It's very low. It's like less than 100 every single year. I haven't checked the data for like this year or last year, but up until this point, it was less than 100 women. And so there are challenges because everybody says that's what they're using as a referral source. And people are not using it. Okay. So that was to me, it was a very applied problem. And one of the things, you know, we could think about was income, for instance. You know, even with some of our participants, I'll talk about that later, you know, they just, their phones get disconnected. And that is also a problem with text messaging. But many of us probably have unlimited phone plans. But if you don't have an unlimited phone plan, do you want to spend your precious minutes talking to a Quitline? And then there are also other challenges to in-person counseling too. If it's not linked to a healthcare visit, having to go somewhere, there could be transportation barriers. So the other piece is that there have been effective interventions, including incentive-based interventions. But often these interventions are designed either for people who are smoking and are ready to quit, or they're designed to prevent relapse. So somebody who successfully quit and preventing relapse. And so there's some gaps in care. There are a number of health benefits to maintaining smoking abstinence postpartum. And one of those health benefits is that a mom might be less likely to smoke in subsequent pregnancies. There are benefits to for existing children, that they're less likely to be exposed to secondhand and thirdhand smoke. But really, what got me is that we could reduce, if we can get women to stop smoking in their reproductive years. So, you know, in their 30s, we could reduce 90% of their excess risk for lung cancer if we can get them to quit smoking postpartum. And so one of the things that people often emphasize when encouraging women to quit during pregnancy is you have to quit for your baby. And if that was the messaging that they're getting and not like you have to, quit for yourself and your own health, like I think we really are missing an opportunity to reduce lung cancer and other causes of mortality among women. So the Moms Quit pilot study was a randomized controlled trial. We enrolled postpartum women, and our goal was to enroll them within 1 month of delivery, because we talked about how quickly women relapse if they are quit. We used Moms Quit, which is our intervention, versus Text for Baby. We did a 12-week intervention, and our primary outcome was days abstinence in the past 30 days. So that's the only thing that we were actually powered to look at differences for. And then we looked at some feasibility metrics. So our inclusion, we wanted women who were postpartum. We actually recruited people during pregnancy as well. We cast a broad net. We tried to recruit from obstetric clinics. We also recruited from pediatric clinics, but the intervention would begin after delivery. We wanted women who had a live delivery because the messaging was all around, included messages about taking care of yourself and your baby. Women just had to smoke anytime during pregnancy, own a mobile device, and provide an email address. The only real exclusion criteria that we had was that on a scale of 1 to 7, if they said they were not interested in quitting or staying quit at all, so 0, we excluded them. We enrolled and randomized them after the baseline survey, so they at least had to complete that first baseline survey. And we randomization was stratified on smoking status, whether or not they were current or former smokers, and we just used 30-day smoking for that variable. Okay, so I'm going to first describe our message library, and then I'll go into our tailoring variables. So our message library consisted of supportive messages that were developed from my co-mentor, Dr. Catherine Pollock's work. So she had newsletters that were sent out to pregnant women. So it was supportive messages about taking care of yourself, taking care of your child, babies, milestones, things like that. And just to give you a little bit over the reasoning for including that in some of our decision making was that she found that women who quit and had no intention of returning to smoking actually did worse if they got more messages about tobacco use. And so we took messages from those newsletters and turned them into text messages. Another set of messages that we used was from the ROSE program. So that program was developed by Karen Zlotnick, and it's a group-based program that it's actually been effective in reducing preventing women from developing postpartum depression. And so what we did is we just took some information from the workbook for that program, and we created messages from that. So I'm sort of targeting like our stress and our depression-related variables that we saw in the cohort study. We also included some smoking-related messages that were more motivational. So talking about the benefits of quitting smoking and giving, just giving encouraging messages to increase self-efficacy. Things like, hey, you're thinking about this, you're participating in this program. That's great that you're doing that. And then finally, we had messages from Smoke Free Text. And so that is the free program available from the National Cancer Institute. You can get the whole library from them, and you have to set a quit date. So the initial messages ask you to set a quit date sometime in the next 2 weeks, and then you get smoking messages that are a smoking cessation program. Okay, so we tailored our intervention on smoking status. Okay, so whether or not they were quit. So if they were quit at baseline and they had no intention of smoking, or they said that they were unlikely to be smoking when their baby was 6 months old, they got our supportive messages, so no tobacco related messaging. And actually everybody got those messages, the non-tobacco supportive messaging, but that group only got those messages. People who said that they may be likely to smoke at the time their baby was 6 months old, but they weren't currently smoking, they got our relapse prevention messages plus the supportive messaging. For people who were current smokers, so they smoked in the past 30 days. We gave them and they were interested in quitting, we gave them smoke-free texts. If they were not interested in quitting right now, we gave them motivational messages and activities. And then we did that same thing that we did with the previous study. We asked them weekly about their smoking status. And that allowed us to change people's track based on what their current smoking was. And we also assessed readiness to quit for folks on track C as well, so that we could switch them over to smoke-free text if they were ready. Our control group was Text for Baby, which is a nationally available free text message service. It's founded by Johnson & Johnson. It's provided by National Healthy Mothers, Healthy Babies Coalition. And it provides health and safety information. It provides public health alerts. It includes information about smoking cessation, particularly information about the quit line, like if women are interested in quitting smoking. We didn't have, this is not a library that we had, and so this gets updated. So for instance, while we were doing our study, it also included information about COVID. We screened 50 participants for eligibility. We excluded 20. 9 of them were eligible, but they didn't complete that baseline survey. We randomized 30 participants, 16 were randomized to our intervention, 14 were randomized to our control group. We lost 6 people to follow up. And I'll show you the differences with our completers only versus our intent to treat. So for analysis, we include descriptive statistics and ordinary least squares and logistic regressions controlling for baseline smoking, which was our stratification variable. So our pilot study participants are kind of similar in age to our cohort study participants. We had a little bit less racial and ethnic diversity, and I think during COVID, we primarily were only able to recruit from KUMC as opposed to having more partners recruit. We didn't look at any statistical significance, but we actually do see a little bit more diversity in our moms quit sample by chance. About 25% in moms quit had less than high school education, 14% in our control group. 63% in moms quit were married or partnered, 43% in our control group. And then at this point, postpartum, a minority of our parts were less than half, way less than half of our participants were employed, full-time or part-time, and many of them were reporting some degree of financial strain. 2/3 of them were currently smoke. 2/3 to a half were reporting tobacco dependence to smoking within 30 minutes of quitting. 30 minutes of waking. We had about 20% using e-cigarettes, which is a little bit higher than in our previous study. And we see that people are kind of like our average is sort of in the middle for that intention to smoke by 6 months postpartum. So 1 would be not at all likely. So those are our people who were not at risk for relapse, and then 5 being likely to smoke. But they were reporting relatively high confidence to quit or stay quit. Okay, so our primary outcome at 12 weeks follow-up, which is an end of treatment for us. We had people in the control group, they were smoking about 22 days in the past 30 days, versus in our intervention group, they were smoking about 10 days in the past 30. And that was a statistically significant difference. For our secondary outcome, which was self-reported 7 to 8 point prevalence, abstinence, we have no statistical significance for completers only or intent to treat, but we see that among completers only, 54% were reporting, 54% in Moms Quit were reporting that they had, they were abstinent versus only 18% in control arm. And when we use intent to treat, that was 44% were abstinent in our intervention group versus 14% in our control arm. Overall, participants reported like high level or good levels of satisfaction. They reported like 80% reported that they were likely to recommend Moms Quit. In both groups, for Text for Baby and Moms Quit, people reported reading most of their messages. And of course, there's more smoking related information in Moms Quit, and so that was a higher score, about 70%. And what's interesting is that participants indicated that the program was helpful for supporting new moms. But perhaps it was the variety of types of messages that we included from the newsletters and from the ROSE program. So this is just a broad strokes indication of, I don't have a lot of analyses on response rates for weekly text, but for each week that they responded to the text, we gave them $1. If they responded to all 4 messages in a month, we gave them a $1 bonus. So 80% of our participants completed all 4 weeks of weekly messages. And that started to drop with subsequent weeks. Weeks 5 to 8, 70%. We had only 1 person who had no responses for that 4-week period. But then in weeks 9 to 12, 63% completed all weeks. And we had 5 people with no responses at all over that period. And that's where I was pointing out that we were also having some people who had lost access to their phone. We couldn't reach them because their phones were no longer active. And that is sort of where, like, having us, I think for another study, what we might try to do is contact people right away. So if they miss a week, we might try to contact them because their number could have changed. So we could use that secondary number, that email, or mail them information to get in touch. So this is a very low cost intervention. We really were just using text messaging. It was all automated. So it could help to increase smoking abstinence among postpartum mothers. At least in the short term, we show that it's feasible to engage them and engage both current and former smokers. And we hope to apply for an R1 and get funded for a larger trial. Here's a hard part, questions.
What percentage of participants had insurance, like medical insurance?
That's a really great question. Because they're from the health system, I would say that most of them were insured. But I don't know how many were insured by Medicaid. So that, I don't have that off the top of my head, but that's a really great question.
So these text messages they're getting about quitting, is it focused predominantly on combustible tobacco use, or would it also include, because you've got fairly 20% rates of e-cig use, for example, is the goal to get them to quit all tobacco products and tobacco related products?
So our messaging was primarily around combustible tobacco. So, and I think that's a great point, because we could ask about e-cigarette and maybe tailor that as well. So include e-cigarettes information for people who are using. Yeah, because there could be this inaccurate belief that, well, I'm not smoking tobacco cigarettes because there is this kind of, again, misconception. Relatively speaking, it might be safer to use an e-cigarette, but that doesn't mean that it's in absolute terms safe. I don't think we know enough about the effects of vaping on developing
babies, for example.
Yeah.
So I think that would be an interesting thing. And you could also plot, because maybe if their smoking goes down, then does their e-cig use go up? Or are they shifting to some other type of stuff? We talked about cannabis this morning.
I haven't analyzed our lab data as yet. But I think I mentioned this yesterday, with a couple of you, but, for some of our, we have like high levels of nicotine and cotinine, but low anabasine and anatabine for saliva. And so that indicates that they might be using, maybe they're using NRT, but it's probably more likely that many of them or some of them are vaping. So yeah, I think that is a great point.
Actually more discreet, they can, we were talking about, pregnant moms who are drinking alcohol, there's that shame, that stigma, that sort of social evaluation. Well, it's pretty easy to pop a hit of the vape device, right?
Yeah.
Not that you don't smell necessarily like tobacco products. So there could be some really interesting things there.
Yeah, I guess just even adding to that, I wonder if the perceptions are the same, versus when you see somebody who is pregnant or a mom who's smoking cigarettes versus is it more socially acceptable to vape?
You said that your mom's quick intervention, you pulled some elements from kind of various established ones. So what would you say was like an organizing principle or theory that informed which elements that you pulled from which interventions? What's the thing that kind of ties those elements together and perhaps contrast it with what your control intervention?
So yeah, that's a good point. What we pulled from, I don't exactly remember the Catherine Pollock's work, like what theory they used. But it was around, behavior change theory, such as, increasing self-efficacy, increasing confidence, those especially. And so we focused a lot on that. And then really I think it really was for us targeting stress reduction and preventing depression. That was what was value added to our program versus other just the smoke-free text, for instance. And it was targeted for pregnant or for postpartum women. So all of our messages was about, what's it like to be a new mom? So some of it was just information that was, hey, your baby might be rolling over right now. And so some of it was just to engage. And then other parts of it was sleep while your baby sleeps. So encouraging self-care. So some of those things, I think, were elements that we built upon the other smoking related intervention. Does that answer your question?
Yes, I mean, it sounds like because one thing I thought about your intervention is doing is yes, you have a control arm, right? But what you're really capitalizing is unique opportunity that's presented. Right?
Yeah.
So it's a part of the uniqueness of the intervention is timing, not necessarily the intervention itself, right?
Yeah.
But then I think what you're saying is that there's elements of the intervention itself that is kind of customized to that timing, like when the baby's that kind of stuff.
And I don't know, one of the downsides is that for tax rebate, we don't have control over what messages got added. So, because there was a lot of COVID related information, and I don't know how all of that was perceived by women. So. Other questions?
Great, thank you very much. Okay, so we'll have one more seminar talk in the month of April, and then I'll be giving Brown Bag next month. So we'll have 2 talks next month, and then we'll finish out the year. Great. Oh, Sorry, I just got a live chat question from Dr. Kim Rick. Have you analyzed the patient exit interview data? I'd love to see what kind of intervention is happening with providers in your longitudinal study.
So, we analyzed it and I don't remember all of the details. What I could say is that, we try to look at, lag patterns and to see if we could see any increase in abstinence but what we found is that higher rates of tobacco treatment or, getting more tobacco treatment was related to higher smoking, but actually that makes sense because providers are probably going to be more concerned about people who are smoking a lot. So that was one finding that we didn't really think was going to be newsworthy or that interesting. And so we haven't really explored that a whole lot, but we were seeing people providing tobacco treatment, but that really varied.
I realized I know Robin. So I heard she already got back to me. It was like, apparently routes AUMed and then it's coming to use. Yeah. Which is. That's good. Economy. Yeah.
Really intensive.
Yeah, I have to. Yeah. Yeah.
Okay.
Yeah.
No, because we're not going to.
Yeah.
Thank you.
Yeah. Yeah, I will be out in April.